Welcome to the Deep Six podcast, where we make a generational impact on you and yours. What we do here is explore a 6-point model into your health, your life, and your journey while you're here. So let's dive deep and help you thrive, not just survive. Well, welcome again here from Dr. Lewerenz, Longevity Health Institute, and the Deep Six podcast. Another wonderful, lovely guest taking their time, ER doctor, a friend of mine. We'll introduce in just a second, but thank you for joining us. And as always, if this is fun, hopefully it's fun, educational, enlightening, and kind of motivating you a bit, subscribe, please, follow us, share this with loved ones, and build a community, because this is what this is all about, just to make sure that your journey here, why we're here, is thriving, and you know, we're really helping your health span. And somebody that's a guest today of mine, a friend, Dr. Roya Caloia, she helps us all when we're desperately in need, because she's an ER doctor. So Dr. Roya, hey, thank you for joining us.
It's my pleasure. I'm so excited to be here.
Awesome. Thank you so much. And I said this the minute I saw you before we went on air. I said, wow, you're coming in hot, because you literally are coming in from the ER. I mean, I saw your car come up the driveway, kind of go sideways, smoke off the tires. You said, so thanks a lot for joining us. And then you warned me that in the background we might see some chickens, which is lovely. I love it. I'm coming over for eggs on the way home.
I'll bring them to you later. We've got overproducers right now.
Overproducers. I like that. Hey, it's better than a kid being an underproducer, you know?
Exactly.
So anyway, listen, Dr. Caloia, thank you so much. Now, just a little background: you are a board certified ER doctor, and you're at Genesis, Henry Ford Genesis, up in Grand Blanc, Michigan. And you went to medical school in Florida, right? Nova South.
I sure did.
Yeah, yeah. And where was your undergrad at? I know this, but
The University of Miami.
University of Miami. Oh my gosh. That had to be fun.
It was awesome. We went to school where you vacation.
Right. I would have failed. I would have made it. You know,
I came this close to losing my scholarship.
Yeah, there you go.
But
See, I mean, that would have been me.
There's nothing like the almost losing your scholarship to get things back on track.
That'll make you, that'll motivate you. That'll definitely motivate you. In fact, it reminds me of when I got into a few medical schools, and one was Michigan State, and my girlfriend, then going to be wife at the time, was at Michigan State, and as well as friends. And I didn't choose Michigan State. And people were like, "What are you doing?" I'm like, "I'm going to Missouri, because I know I'm not going to make it. I'm going to have fun." So
it's a lot of insight you had there.
Yeah, well, I just knew know thyself, and I knew myself that I needed to focus, you know. But anyway, hey, thank you very much. You're going to tell us today what you did, and I know you changed and saved lives, because that's what you do, and I really appreciate and value that, because my community here knows, I did a residency in ER with family practice, and my passion, believe it or not, was ER medicine, and lifestyle kind of ate me up a bit. And so I really value, kind of what you're doing. And to me, it was always so exciting and rewarding at the same time, and so needed, because I don't care, we're all about prevention and proactivity, but shit's going to happen, in life. Things happen, and we need ER doctors, and we need ERs, we need hospitals. So thank you. But also, how did you get on this path? How did you get into ER medicine?
That's a great question. So between undergrad and medical school, I actually got my master's in public health, and I was thinking I was going to go down the health promotion route, and which is something you and I have discussed several times. I love prevention. I love health promotion. I think that there's some aspect of that I can bring into the emergency room too. It's just not always there. The opportunity is not always there. But I going through that, I realized I really did want to go into medical school. So I went to medical school. I actually thought I was going to do GYN-onc, so it's GYN oncology. I was ready for it. And somewhere through my internship year, I realized that maybe that's not for me. And every time I went into the ER, everyone's like, "You're ER." I'm like, "No, I'm not." My best friend who was ER, he's like, "You're ER." I'm like, "No, I'm not." And then, and then I did my rotations, and I had also done a medical mission trip with the school down to Guatemala. I did my rotations in ER kind of late, and I don't know how much of this you remember from way back when, but the ER rotations are usually later in your fourth year. So you've
Yeah.
set up your decision. And I didn't come from a family of physicians. My dad ran a restaurant, and I just knew the restaurant business, which really kind of translates well into emergency medicine. But I, but I didn't know about it. And once I started doing it, I was like, these are my people. I
Hmm.
love practicing emergency medicine. And so I made a switch and I said, I want to do emergency medicine, but it was after the match. And I pulled myself out of the OB-GYN match. And I said I would even go to Michigan to practice
I
emergency
would even.
medicine. Back
This is how desperate I am. I'm going to go from Florida to Michigan.
I was a born and raised South Floridian, and so I ate my words when I found out on April 1st. It was April Fool's Day. I was standing in Mount Sinai's ER parking lot having an interview with Dr. David Maliki at
Oh, I
Oakwood's
know.
program. And he offered me a spot. I was like, "Is this an April Fool's joke?" And he said, "Come on up." I came up 2 weeks later, and then I moved here 2 months later, and here we are. Emergency medicine for me, it wasn't about the lifestyle, it wasn't about anything, it was just I had fun. Every minute I was there was something fun, but even more than that, it was an opportunity to truly impact somebody's life, right?
Yeah.
Whether it was giving them an answer, right? Like just being able to answer something that they haven't been able to answer outside, or they have an acute thing that happens, a painful process, they've had a heart attack or an ankle sprain or something. You have an opportunity on that person's worst day to be there with them and to be able to hopefully get them to the next place, whether it's home or upstairs or transferred or whatever it might be. Um, it's fun, and no 2 days are the same. You've got a lot of cool people that are also in there with the same mindset and are here to help people on their worst day. And so it's fun. It's cool. I feel like it's a huge honor to be able to do it. And this many years in, I still have fun when
Yeah.
I show up and get to help people. So it's the best field for me. I
Yeah.
could not imagine sitting at a desk all day long. It's just not what I was made for.
Yeah, yeah, no, and it shows, by the way, and you're so needed, so it's I mean it's an amazing field. I personally loved it a lot of times because it is exactly what you said. You would be able to impact somebody's life and give them an answer right away. People will come in. What people often don't understand, lay people and people are not in medicine, even if they've gone to the ER once or so, is, and this sounds like negative, I don't mean it in a negative way, but the ER is like a dumping ground. It's like anything and everything in medicine can go there because it's not just the urgent emergent cases often. It's people that really didn't have a resource or have an idea or have an option. And they would walk in, and sometimes it wasn't even that complicated, but you could, appropriately intervene and give them an answer and give them a direction. Yeah, it's so rewarding. Hopefully, that's not gotten worse. I'll ask you that, but is it becoming too much of a less urgent emergent cases? Do you think?
It's funny you mentioned that. I think I feel bad for people with the way that sometimes, whether it's their insurance company or someone says, well, you have to switch this primary caregiver, or it's hard to be a primary care provider these days, and it's become even harder. So there's fewer and fewer of them out there. And or the ones that have established care, I've been with them 25 years, you don't hear that story as much anymore. The docs that would see their patients and go into the hospital, see their patients, knew their family, delivered their kids, did their endoscopies, did all this stuff. You don't hear or see that as much anymore. So patients don't have that relationship that they've built
Yeah.
in, and the stressors that the primary care providers are under to see 50, 60 people in a day, you don't develop those relationships. So I think that coupled with life, right? people are keeping 9 to 5 hours, but 9 to 5 is not when a single working mom of three can bring her kids in because they all have, an ear infection, runny nose, or what have you. So, yes, are we the catch all? Sure. But I also think that that's an honor to be able to be there for people. The ideal state would be that the resources would be there for our
Yeah.
community so that they can go
Yeah.
to their providers. But sure, yes, I would
Yeah.
say that has increased. There's a lot more of that. Um, I don't know that I can fault people necessarily for
Oh,
it,
no,
you
no, no.
know?
It's yeah, they don't have access and they don't have opportunity. In fact, we don't run a practice, like that. In fact, we, see 10, maybe 12 people, all my practitioners a day. In fact, that's 12 people is kind of a busy day. Um, you know, all our patients get 30 minutes or more, and new patients get an hour, and they get what they need, whatever they need. And so there is that relationship, and it's completely different. And honestly, I believe that that's the only way in a primary care, whether it's what we do like functional medicine, deep root cause medicine, good internal medicine. But that's the only way really good care and relationships can happen. They can't happen in 3 or 5 minutes and somebody seeing 50 people. And then also there's a logjam. There's less practitioners. There's less options. The insurance model just bottlenecks you. So of course people are running to the ER. But what the really important thing is, at least from my perspective and how I coach my patients, and that is if you have a good doctor with a good relationship and they're telling you to go to the ER, you should listen. And
Right.
I bring that up because it just happened this weekend, Sunday night, yeah. And I had to beg the person who respects and trusts me, but we had to have I almost got a little pissy, let's not be a fool. And by the way, he was having an MI, he was an SVT at a restaurant. Didn't want to go because men, were stoic and tough, and maybe it's something I ate and that kind of conversation. But so needed an ER, okay, and that's the purpose of him. And fortunately, he went and he's fine, and it was home the next morning, and I've already seen him. But my point is that it's so important to listen to your practitioner if you have trust and a good relationship. But that is getting lost a bit because it is a mill, and again, people are getting bottlenecked into, they don't have that option, But thank goodness you are there.
Aw, thank you. And I'm glad your friend or your patient is doing well. You bring up a really good point, right? I think there's so much to say for that relationship that you build, and that's probably one of the bigger ways you can get patients to actually change behaviors is because they trust the provider the physician that's taking care of them, and they've built that relationship. And I used to see that so much, like, well, Dr. Lawrence said this to me, and I don't know that I can trust you because he said this to me. And now I can't get people to even tell me who their primary care provider is. They don't
Yes,
know.
yeah.
The office has
Mhm.
changed hands. They haven't seen the person at all. And it's
Well, and not to
so
interrupt you, but there's something
transient.
huge that's happening nationally. You know this, but I mean, I just got to tell the audience that is horrible. Is the corporatization of primary care, internal medicine. Private equities are coming in, gobbling these up, and all of a sudden people are numbers, and physicians are employed, and not I'm not talking even hospital-wise. I'm talking employed in these medical settings. So they're not making any decision as far as from how the office is run, the customer service, the staff, the everything. And it's why the growth also of what we offer in our practice is, and nationally this is happening, is concierge medicine or a direct pay model, because you get what you need, which is a relationship and time, and then that trust, so that real healthcare can be delivered.
Exactly. And I think that that is so important. It's going back to the basics, right?
It's going back to old
No
school
one.
medicine.
Yes,
You know,
exactly. So much of it is about that relationship. And in the ER, we're in a little bit of a, you know, um, disadvantage because it's hard to build that relationship in such a short period of time. You need to get people to trust you in 30 seconds, right? And to be able to believe what you're
right.
saying.
So you
And
better be good,
yeah,
and you
and
better be
so
smooth.
there's And there's so much that goes into that, right? We have this discussion often. Why make it so much more difficult for someone to be able to trust you? I get it a lot, even at my very old age, where people are like, "Are you old enough to be a doctor? Do
Oh,
they let ladies be doctors?" You know,
that's kind of cute though.
it
Oh,
is
you're a
also.
doctor, really? you know,
But it's it's so important to build that trust because uh you are there really is it's one of their worst moments. People remember their time in
hmm
an ER for years
no,
and years and years to come.
for
I
sure.
still remember, I think I was 5 or 6, and my sister had stuck a bead in her ear. She was 4, and I remember her screaming, and they had her held down, and I've had to do that to people since
Mhm.
then, but I still remember that, and,
Yeah.
so it's a unique place to be in to be able to try and build those relationships, because they're not always getting it outside, right? Your
Yeah.
patients are fortunate to be able to get that, and I would bet that every single physician that's practicing now wishes they could have that same model. But unfortunately, I don't think they teach business in
No.
medical school,
Well, they don't teach business. They don't teach insurance. Okay.
right?
They don't teach anything really outside of the medical world. So even, and I know it sounds weird, even if it's not your practice and you're not running it and that, but even just how to handle people, how to, besides outside the examine room, so it becomes like, baptism of fire and learning. And I'll never
Right.
forget some of the things when I came out and I chose more of got out of ER and urgent care kind of moonlighting, if you will, work, and did mostly work with my father in primary care, just family practice, a little bit of sports med and stuff, but mostly family practice. And I saw and understood some of the insurance model and some of the payments and some of the HMO stuff. And I was like dumbfounded because that was never discussed at all anywhere. And then somebody administratively telling me, and this is hand to God, and an HMO came to me and said, this is like my year 2 in family practice, that I owed them money for seeing their patients. Can you imagine that? That happens.
No,
That
that's
happened.
crazy.
$1,500.
Wow.
I owed them for the quarter. Of course, they didn't want to check. What they do is they take it out. But my point here is in this HMO is I was an overutilizer in their they had too many X-rays or too many labs or too many urines or whatever. But by the way, I wasn't doing surgery. But I was like, what are you talking about? Like, I saw the patient, I ordered what I needed or whatever, and I was an outlier costing too much money, too much, maybe an MRI, whatever it was, CTs. And, and he came in and had a meeting with me because he wanted to correct the ship, and guess what I did, by the way? I'm done. Got out of that HMO. Like, what do you mean you're going to
Love.
tell me how to practice medicine so I can't do what I need to do for the patient? So, but anyway, sorry to get off on that tangent. But yeah, you're taught no business. You're taught no, what it's going to be like to deal with employees and, HR and stuff like that. And so it is tough. I think it's actually a unfortunate thing that should be somehow incorporated in training. I actually believe, unless you're, like yourself, I believe, right? Aren't most ER docs employed mostly now by hospitals?
Actually, no.
No. Oh,
So,
okay.
yeah, it's multiple different ways. So there are hospital employed ER physicians. There are also group employed physicians, and then the groups all are different. So then there are the national groups, which I work for. There's also smaller, like regional groups that might only staff within Michigan or within a certain area of Michigan. And then there are some groups that only have 1 or 2 hospitals. So there's different
Okay.
models for employment for emergency medicine.
But most, nowadays too, though, the most, primary care, internists, pediatricians, family doctors, stuff like that, most of them now are employed by somebody or they're a big group or that kind of thing. So very similar in that way. But I think you need to know the business a bit. You need to understand, but I don't know. I'm of the philosophy, obviously, I've been doing this 8 years in the concierge world or direct pay world. It's not new to me. It's not going away. In fact, actually, I believe probably I'll be long gone or, my wife says dust. But Roya, come on, you're supposed to laugh. But my wife. She's like, oh, he'll be
True.
dust. He'll be a barnacle. He'll be dust. But anyway,
Aw,
no,
I
but
can't imagine her saying that.
well, it makes her younger, but anyway, so no, but literally that most primary care will be, or there'll be a majority I really believe will be direct pay models, concierge models, whatever you want to call them, because patients will demand, and insurance is going this way, that they're not getting coverage in a primary care setting anyway. A lot of them, at least a lot of them aren't. But hey, let's quit this boring talk about this. We got to talk about something exciting.
Oh,
There's got to be ER stories, and today you did some. I know you text me on the way. So what goodness did you deliver today?
oh
And there
goodness,
go the chickens
today.
behind you. I love the chickens behind you. You weren't kidding. There's about 6 or 8
No.
running back there.
They are funny. So what goodness? Well, there are some good stories today. We
Yeah.
had patients with strokes that we were able to help, which was amazing, right? Someone who goes from not speaking at all to improving within the time that they're there. Folks that have been not being able to get answers outpatient, not be able to get answers outpatient, came in and we were able to identify one of their reasons, like why they were having this increased heart rate. It was their thyroid and it just hadn't been checked yet.
Yeah.
So there's a lot of reassurance that we were able to offer. I have to be careful. I'm trying to go through my patients in my head without violating any
No,
HIPAA
no,
and
right. I
making
would, yeah,
sure, yeah.
exactly. Yeah.
Yeah, there's some really they're funny stories. I mean, it's fun
Yeah.
to be able to paint a picture. I know some people have watched the show The Pit of what the emergency room's like, and it's actually very accurate from what I understand. My husband, as you know, is also an emergency medicine physician, and I told him, I was like, "This seems great. They say it's like super realistic. We should watch it." He's
What's,
like, "Why?
what's it called?
Why
I've
would
never
I?"
heard of this. The
It's
Pit?
called The Pit, and
Oh,
Noah Wiley, who was in ER way back when,
yeah.
is also in it now,
Okay.
and the guys that are behind it are actually emergency medicine giants, and so
Okay.
it's very true to form, and
Hmm.
it really covers a lot of what we do. It's set like, do you remember that show 24 where they did one
Yep.
hour at a time per show? So it's set like that, a little unrealistic with how much they fit into an hour,
Yeah.
but for the drama a little bit. But the cases are all very real cases and give you a great understanding of what's like in the emergency room. I have a good friend who's a hospitalist, and he was laughing. He's like, I don't know how you do it down there in the ER. It is a zoo. You've got psychiatric patients running through naked. You've
Yep.
got people yelling because they want to be seen because of their ankle sprain. You've got people actually dying, people that are suicidal, patients that are having heart attacks, patients that are having strokes, patients that have horrible infections, diabetic ketoacidosis, super sick, and needing to go to the OR, people falling off ladders. So you
Yeah.
have, appendages that are everywhere, and then you get the fun ones
Yeah.
where we had this patient who was prescribed a drop for her conjunctivitis by an urgent care. But when she got the bottle, it said Odic. And she looked it up, and it's supposed to go in your ear. Odic means to go in the ear. So she was putting it in her ear and wasn't sure why her eye wasn't getting any better. And that's like such a simple
Oh, seriously.
aha moment. Yes.
That
And
I've not
so,
heard of. Yeah, I mean, I know what you're saying, and Odex can, be used for the ear,
yeah.
or for the eye, excuse me. But oh my gosh, wow, I have not heard that. Usually the doctor would explain that, but maybe not,
Mhm.
maybe it was miscommunicated or not received. But okay, well, that was a simple fix.
Simple. I'm like, look at this. We're
Yeah,
we're saving people today. But it's little, we're tapping knees, we're
yeah,
fixing arms, horrible fracture dislocations, open fracture dislocations of ankles, making sure that people don't have anything worse going on with them, right?
yeah.
So it's fun. It is, like I said earlier, no 2 days are the
Are
same.
the same. No, 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 no.
Yeah.
Yeah,
It's
one of my favorite stories. I won't use names, not HIPAA, but like the doctor, because he's awesome doctor. But man, he really gave it to me. I was a resident, and I was so proud of myself, a first year resident. And a older lady came in. She was bradycardic, and long story short, I floated a pacer in her. Had it captured. Nowadays I don't. You guys are probably way more high tech than this, but I'm looking up at the screen and you could see it. It wasn't. Her rate was back in rhythm, and her heart rate came up, and it looked like I had captured. And I sewed it in and all that. Well, the way I sewed it in. So by the way, she's awake. She wakes up. Boom. She's awake.
amazing.
Her blood's flowing to her brain. So she's thrilled. Family's thrilled. Everybody's thrilled. Well, I sew it in the shoulder just to stabilize it. Okay, and something with the catheter that you can readjust. And forgive me. This is, I mean, literally 25, 30 years ago, and something with that I did wrong, so you couldn't adjust it. And
Oh,
so cardi, what I'm talking about? I don't know. Maybe it's
I
not
sure
done.
do.
Okay, yeah.
No,
It's anyway.
yeah.
Anyway, so the cardiologist comes down, and we actually we had a good rapport. I had already done his rotation. I mean, he liked me and whatever, and I was so proud of myself, man. My chest was pumped. I was so, and this lady's happy, family, everybody's happy, and all of a sudden I hear my name being yelled down the hall. Where's Lewerenz? And yeah, I heard about how I did that wrong, but I was like, hey, she's alive.
We've come a long way. Less yelling. When I trained, we had one of our medical students lost a guide wire, got thrown across the emergency room. Never did it
Oh,
again.
oh yeah, yeah, yeah.
Not condoning
I,
that
by the way,
kind
I
of
never did that again. By the
behavior.
way, that was done.
Exactly.
Yep. I learned.
You do,
Yeah.
but you'd fix the patient. It was not irreparable. Like it could still be fixed.
Right.
It's it is. We see that sometimes, but we try to help a lot of our learners not make those mistakes
Yeah.
by going through these stories, right? Like this
Yeah.
is one of the things you don't want to do. But that's amazing. I commend you as a first year for floating a transvenous by
Oh no,
yourself
no.
with,
So
and then
you're a
telling.
DO though, right? You're a DO,
Mhm.
correct?
I sure am.
Well,
Mhm.
so right, yeah. I just wanted to confirm. So in DO, at least for the audience, in hospitals at least, they were at least back then, in my times. So this would have been 90, trying to think, 92, 93. It was literally see one, do one, teach one. And, and obviously there had to be trust with your senior doc you're with, and whoever's you're working with and on call with at night or whatever, and, or your senior resident or whatever. But long story short is that's what we did. You just and you saw one, you did one, you practice it, and then you teach one. You should be that good. Well, when I went down to Henry Ford downtown on rotations, and I was in the ICU, I was doing radial lines. I was doing central lines. I was intubating people. I was doing all this stuff, and they could not believe it. Third, fourth year residents could not even. They were like, now they were probably 100 times smarter than me. But that's just what we did. DOs, you learn and you do. Part of my training was in rural medicine. I was in Missouri, so we literally, the doc I trained with as during my externship, we went, from his clinic where he probably saw the local town people to, oh, somebody's got chest pain and is in an MI, in the ER local that has like a 5-bed ER. We get in the car and go flying down the road. So,
It's amazing.
yeah, yeah. So, DO is you do a lot. You get comfortable doing a lot.
100%. I even speak about that with my residency program. You did, and you learned by doing. And I think it made us all great as a result, right? Like you really got in there and you did things. There wasn't as much of a barrier
Mhm.
to seeing the patients and doing the things that you needed to do and learning as you went. And I still remember all of those cases and the patients that I saw while I was training. And one of my favorite places to work was this little 12 bed ED, and it was awesome. I really was able to practice emergency medicine there, and you are doing all of it, just like you said, right? I'm not doing endoscopies or anything on these patients, but Brad was there, and he had done his half of an open chest because the patient had lost pulses and it was a trauma. It was just him and the trauma surgeon that drove in, who lived a couple miles away.
Yeah.
And
Wow.
and then the next room is respiratory distress patient, and the next room is a little baby that was colicky overnight. So it
Hmm.
was just a fun little bit of emergency medicine. And I think the DO training, to your point, gets you ready to really practice anywhere in
For
any
sure.
setting. And the
Right.
majority of the ERs are in community settings. They're not the big academic level one
Right.
tertiary care centers, right? And in those settings, not to discount from the folks that are training there, because I think they also receive excellent education. There's so many other learners there
Yep.
that they're not maybe getting 100 nosebleeds or a
Right.
100 ears that they're looking into, or foreign bodies that they're removing, or bones that they're setting, because there are other trainees that are doing those things.
Yeah.
So
Yeah.
I think the training that I received, that you received, gets you ready to practice in any functional ER across the country.
Yeah, yeah, no, I don't know, I love being, I didn't know, by the way, my dad was a DO, so kind of was innate, and we were athletic, and we were, fairly healthy, I'll say. Didn't do all the stuff I do now, but we, at the time in the 70s and 80s, and, I grew up in a very kind of health-minded family and all that, and so him
I'm
being a
shocked.
DO and
Knowing your
adjusting.
sister, I'm shocked.
What's that?
I said, knowing your sister, I'm shocked that you guys grew up in a health family.
Oh,
You guys
yeah,
are
yeah,
all like
yeah.
so healthy. It's
No, well,
amazing.
yeah, but I mean, this was also the, 80s, and, is when I'm saying what we know now, it, probably wouldn't have done, but my point though is that, so my dad being a DO and adjusting people, and, having that type of philosophy, it really worked really well. I didn't, it was just innately to me. I didn't even think twice about it. Didn't really even fully understand. It was just like, well, my dad's a DO, my brother's already in DO school, that's why I guess I'll go. But what I love about it is that functional thinking that is innate to me now, and, looking at root cause stuff, and actually I think it really even helped me when I was an ER resident and in the hospital a lot, because it's just a different way of thinking, and like trying to get to the really root, like what's really happening, and, not just looking at something that could be just super exciting, but
Exactly.
I do want to bring this up though. I got to bring this up because, and I'm going to probably mispronounce it, but I found something on the internet about you.
Oh,
Okay.
goodness.
Should I drum roll this at all?
It's
But you are the National Clinical Board, right, director or chair of ER medicine through, is it Femini? How do you say it?
feminine.
Right. So Females of Emergency Medicine, correct?
Hmm.
So
So
tell me
it's a
about that.
funny. So Femini is an organization that Dara Cosset started. She's excellent, New Yorker, so strong, like so emergency medicine through and through. And I am a speaker for them. But my role, the chairman of the National Clinical Governance Board, is through U.S. Acute Care Solutions. So we have a group that staffs 400 hospitals across the country, 27 different states, and I get to be the chairman of the National Clinical Governance Board, where it's a board of just physicians, where we decide the things that are most important to our patients, our physicians, and our APPs that work within our organization. So every single day, I get to sit down with the best minds in our organization and really ask that same question. Is this the right thing for our patients? Is this the right thing for our physicians and APPs? And if the answer is yes, then that's a clear marching orders for our operations team to do that next right thing. So it's really
Great.
an awesome honor to be able to do that role.
Yeah.
It's something I've been doing since May 1st. I was the vice chair prior
Well,
to that.
congrats.
Thank you very much.
Yeah.
And I was also the national director of clinical education for the organization prior to that, too. So, education, teaching, and making sure our physicians, APPs, and patients are taken care of across our 11 million patients and 6,000 physicians and APPs is an honor and a very amazing job that I get to do.
Yeah, cool. So cool. You fit it perfectly. Very articulate, and you have an excellent reputation. So they're lucky to have you.
Thank you. Thank you so much. I appreciate that. I feel
So
very lucky to do it.
so you got to tell me though this. You got to tell me something. If there was one thing, or not even one, a couple things or whatever, but to tell the community out there, about going to the hospital, if you will, or about gosh, what they should make sure that they're doing, or maybe something that's frustrating for you as a physician in the ER, and what you see that, wow, I wish they did this or could have done this or, thought of it differently. Is there any advice you could give to, our listeners just about hospitals and ERs? Because I will tell you one thing that I get, and now granted, I'm a concierge physician, so that's a whole different level. But if I send somebody to the hospital, I have to one of the biggest conversations I have to have is, listen, you need to go, and this is why medically. But it's not that, we're not going to the, Ritz-Carlton, and people are there sick and dying and ill. And so be patient, you need to be there because we need an answer right now. And I don't have that ability or a scanner or whatever it is. And I have to coach them to that because part of, I think it is that people have such a short attention span, and, we're used to everything super fast food, fast this, fast that, fast cars, fast life, everything that they think the hospital and ER and stuff like this should be super fast. And, that's just my take, but, is if there's something, at least me, I don't send people to the ER unless they have to be there. Cause I know you guys are super busy. You don't need them there, believe me. And it's not the best place to be unless it's needed. But what kind of advice could you maybe, tell from your experience?
Great question, number one. So thank you
I
for
know
the
loaded. I
question.
know it's loaded.
You bring up an excellent point. I think, we think if someone's waiting 3 hours, right? They're like, man, 3 hours and I still don't have anything. But at the end of those 3 hours, I can give them a CAT scan report. I can have the testing done. They've been seen. They have blood work that's done, and all of that for an outpatient provider to be able to arrange would take a week. And so I think really, and maybe sometimes even longer once you get it approved by insurance. I don't even
Right.
know if anyone has insurance when they come to the ER. And so I think really putting that, I understand you're worried and I'm worried about what you're worried about too. But really, if you were going to try and do this outside, it's probably going to take a lot longer. So maybe it's 3 hours, and I'm sorry it's taking 3 hours. And if it was up to me, it would be 1 hour. But there's also the people that you're not seeing in the waiting room with you that are being rushed back because they're being brought in by the ambulance. And it might be that they're dying. It might be that there's a family member that we're consoling because their family member just died. It might be a baby that's receiving CPR. It might be like multi-system trauma that requires all hands on deck, and we're transferring them, flying them out. There's so many things that are happening outside of the waiting room, and know that you are just as important to the physicians and APPs and residents and everyone that's taking care of the patients that are in the main ED. But sometimes we have to triage, and we do our best to triage and get our sickest patients back. So please have open communication. Let us know if things are getting worse. Know, and please be patient and know that it's not our ideal way of practicing either, but we have to be ready for that bus that drops off all of the patients. Maybe it's a bad toxicology case, maybe it's an abuse case, maybe it's something just really horrible, and if you haven't been brought back yet, that might
There's a
just
reason
mean
why.
that there's someone
Yeah.
that requires our attention a lot more. But it doesn't mean we've forgotten about you or that you're not as important of a human to us. We just have to be able to triage our attention to patients that might just be a little bit sicker in that moment. And so I think if you can kind of keep that in mind and have the patience with us that we would love for you to be able to have, but know that we want to see you just as much, and we want to get you home or get you upstairs or get you taken care of just as much as you want us to. But sometimes there are other things that are competing for our attention in that moment. And they're not scheduled things, right? It's not
Right.
that I
Yep.
scheduled you to come in at 9 p.m. and also scheduled the four-car accident and the heart attack and the stroke to come in at 9 p.m. and I'm mismanaging my time. It's just that it's the emergency room and
Yeah.
we have to be ready for everyone. I think that'd be number one. Number two, I would say if you could have a list of the medicines you take, your physicians, your surgeries, it is amazing. I love my patients that have their lists. Sometimes they're laminated, sometimes they're crossed out and they don't need to be laminated, but and the handwriting's beautiful and sometimes the handwriting's not great. I can usually figure it out, but that list is so helpful. And if you have the ability to do it on your phone, amazing. Take that time, write it down once. You're going to be asked for it no fewer than 500 times. And we're working on things to get AI to help us to decrease that number of times we ask you the same questions. So if you can do that, that would be amazing for both you and for the person that's taking care of you. And then also don't get too frustrated if you're asked the same questions over and over. I know we all know this is not your best day. And the last thing we want to do is ask you these questions over and over, but each person that's asking you those questions has a different level of experience or different reason for asking those questions. And sometimes the last person to ask you those questions is me, but I really need to be able to hear it from your mouth. I'll try to summarize what I know, but I need to hear your story because there might be something in it that other people might have missed that I'm looking for, and I need you to be able to tell me so I can tell you what's going on with you. So I think those would probably be my three biggest things that I would love for people to know about the emergency room. It's not, we know it's not fun being in the waiting room. We would
Yeah.
have everyone back in a bed in a heartbeat. That's our ideal state. But sometimes you just can't control for that.
Yeah. Yeah. And that is excellent advice. I mean, excellent advice. And the reason I say in a not acute setting, in a planned visit, in an hour appointment, and I got all you have all of my attention, and a new patient will come in to me, and maybe not know meds, or I've asked them a question and they will literally, and it is what it is. It's just human nature, but they don't think of or forget or recall of what I asked them or something that they didn't kind of put together, and then the next visit or 30 minutes or an hour later they say, oh yeah, well I do, I don't take any medicine, and then oh no, I do take this whatever statin or this beta blocker, and I'm like, oh okay, well that's important. I need to know these things, and that's in a not acute setting. So in an acute setting, you need to know everything. I mean, the more you know, the better. So yeah, be patient with that, because yeah, getting all the information is going to help you deliver the best care. So that's really really important. So well, wonderful. So I can't thank you enough. I'm going to let you go, and mostly because I could keep you here for at least an hour or two more, because I would ask you all these crazy, wacky ER stuff that I miss because I haven't seen it in a long time, that I used to see, and that 90% of the time had good outcomes, but they were definitely interesting, and I won't forget them. And but I appreciate you. Thanks for rushing home to do this interview and be a guest here. And it is really enlightening to just have some perspective on hospital care, ER care, and acute care. And I know you deliver the best with that. So thank you so much.
Thank you so much for having me. I will tell you, it has been an honor to be on, and I'm sorry I was in a rush.
No,
I
no.
think one of the biggest things I would also say is don't be scared of going to the emergency room. That's what we're here for. We're here to help you relieve some of the fears that you're having. If you're having chest pain, if you're having, difficulty moving one part of your body, if you're having something happening to you, that's what we're here to help you with. I know through COVID, folks were so scared of getting COVID that they were having strokes and heart attacks at home.
Right.
And
Yeah.
yeah, I never want to hear that again. And please know that you really do take that time to understand your patients, and you get into that and you have develop those relationships. And if you're telling them to go to the emergency room, you have a really clear reason for it. There are some providers that are so busy, and the patients don't even get past the if this is an emergency, go straight to the ER, or don't even get to speak to the physician, and it's just a receptionist that says go to the ER, and the physician never even hears about it. And I understand why that happens in the outpatient setting, but I don't ever want anyone to feel bad or guilty for coming into the ER. But just know that sometimes we don't find an emergency cause for something that's happening. That doesn't mean that it's not happening. It doesn't mean there's nothing wrong. It just means within the confines of the ER, we're geared towards, is it going to kill you? Is
Right.
do you of the OR, right?
Yep.
And then there's a big lot of medicine, like, there's a ton of stuff
Yeah.
outside
Yeah.
of that. So I think that's a common misconception for, like, "Oh, I'm sorry I wasted your time." You didn't waste my time. You didn't know whether you were having a heart attack or if this was
Yeah.
real.
No, no.
I
Absolutely.
best to tell you that, right?
Yeah.
And I think it's the same thing, on the other side of it. You don't know sometimes until you get into there and you ask the questions and you risk stratify and you hear the story and you listen to be able to put your mind at ease. And so I think use your ERs when you need to, especially if you don't feel like things are getting better. But know that sometimes there are going to be folks that are just a bit sicker that need our attention, and sometimes it'll take a little bit, but we'll
Yeah.
get to you
Yeah.
and we'll
Let me
hopefully get you
ask you
feeling
one.
better.
You just, when you were speaking, I thought of something that I did not ask you, and this is important. So, of course, we're always on this paradigm of prevention, proactivity. It's what our 6 point model is. And, in that, we always talk about decades out, years out. And you made me think of something that I got to ask you just at the end here is, you know, we talk about the top 10 causes of death, and they don't change much, by the way. They adjust a little bit. Sadly, actually, number 10 kind of just creeped up. It's actually suicide, statistically. But, the top three are cardiovascular disease, cancer, and it's really close, but incidental accidents, injuries, medications, things like this, and then also obviously respiratory, infectious respiratory stuff. What is, just say in the last 5 years or since COVID, maybe, I don't, what would you say is you notice? I could tell you statistically what I think or what I see in studies, but what are you seeing coming in more in the ER? What would you say?
Depression, anxiety,
Really?
suicidality,
Wow.
so
Jeez.
much more.
That's so sad.
So my first six patients today, first six out of six at 7 a.m. today
Oh,
had depression, anxiety, or suicidality.
gosh. Wow. You just blew my mind there because, I mean, we know the statistics, and we know that and literally suicide just went to, I think it went up like 2 or 3%, which doesn't sound like much. That's a lot, actually, in the death rates, and it went up to number 10. And that's just blows my mind, and it's so sad. And I can't help to think, and again, this is a whole nother podcast that maybe I need to have you on to get into, but I can't help think that it has to do with like social media stuff and just our world and how we're handling, just we're not in reality. We don't live in the moment. We don't live in nature, and we're just in technology and fast. And then, and then I have to ask you, it's got to be a little bit the youth, I assume.
100%.
Yeah.
I remember when I saw my first 8-year-old who was suicidal,
Oh
and
my
I was like,
gosh.
how do you even know what that word means? How, who has exposed you to this? Why, how bad is life that you at 8 years old are contemplating killing yourself?
Yeah. Jeez.
And that just blew my mind. My kids were younger than that now, and they're 11 and 8.5 now, and it started. I'm like, what is happening in this world? And
Hmm.
you and I have spoken, and I love your wife, and she and I speak a lot about different things. And I've read Peter Tia's book and Michael Easter's book, and so much is really and I think so much of functional medicine too is just getting back to the basics. Unplug, go outside, go for a walk, get outside in nature, fresh air, move your body. Uh, you know, eat things that aren't processed, maybe buy chickens just to drive your family crazy and get
Collect
fresh
eggs,
eggs,
right?
get
Yeah.
honey, grow a garden, things just going back to the basics. It's someone I grew up in Miami. I grew up in a little apartment in Miami. There's no country in the city, girl. And
Right.
we had got chickens, we got bees, and people are like, why? I was like, the world has gotten so crazy that
Yeah.
sometimes you just need to touch grass, smell
Yeah, for
fresh
sure.
air, throw a ball outside
Mhm.
with your kid, go for a walk, just
Yeah.
like the simple things. And I think people feel more connected with social media, but I think we're more
We're disconnected.
disconnected.
Oh, whole completely, completely. Yeah, and
You
it
can't
actually
have
it causes
conversations.
yeah,
Yes.
exactly. Yeah, and it causes so much dysfunctional thinking. And again, we we could go on and on into this, and maybe I should have brought this up earlier. So I'm going to have you on part two, Dr. Caloia. But it's just that just is disturbing what you just told me, but also not that shocking. And I think you're 100% right. People just have to unplug and get back to basics, and literally focus on what's in front of them, and nature and food and movement and air and sun and basics, and it can make a huge difference. Huge difference.
I think
Well,
too, like
yeah,
what
yeah,
I get to do for a living, every day I'm reminded how bad things can be, right? There's every single shift I go in, someone's breathing their last breath. Not that, not because of me, but sometimes it's just the way it is, right? It is the end of life for someone. And a lot of times in our regular lives, it might not be, until grandma dies or grandpa dies that you are faced with that, or a friend dies, or, one person that dies. And then you're like, "Ah, life's short. Let me get back to the things that matter." And you're reminded and you're good for a while, right? And you get back to the human connections. You call your mom, you go out to lunch with your friends instead of just texting them. And then people slowly trickle back to their normal habits. Every day I get to see how short life is. Every day, just like the incredible men and women that are police officers and firefighters that respond to accidents and are those first responders, every day you're reminded of just how good we have it. And I think sometimes when you are in a bubble and you are just on social media and you are maybe not getting outside of the world, you lose that point of reference. You lose that comparison to the rest of the world. You don't realize, and traveling, right? There's so many things that you could do that makes you realize just how big this world is and just how good we have it, and brings you back to that gratitude.
hmm
And I think that alone is such a big antidepressant, to be
for
able
sure.
to
Yeah.
have that
Well said.
gratitude.
It is a huge antidepressant. Yeah. In fact, actually, I empowered. I do these rituals every year. Start January 1, do every year, and I'm in the middle of it. Obviously, it's September, or so, and it's I start every day with a gratitude list. And I tell my patients this all the time. The best thing you can do in the morning is drink a glass of water, not coffee. Start your day with 5 things you're grateful for, and it can be as simple as you don't you have 2 arms, or 2 eyes, and you can see or taste. It doesn't have to be just about deep emotions about your children or something, which is very valuable. Don't get me wrong. In fact, my lists are kind of goofy. They go from kids to dogs to like, hey, I can feel my feet. But the point is, starting your day with gratitude and basics and appreciation is so like you said, it's an antidepressant. It's like, hey, life's pretty good. There's many things, especially in our first world country that we live in, that we can be grateful for.
100%. And this is not to diminish mental health and depression or any of that, but it is so much easier said than done to sit down and write a list of things you're grateful for. But I'm with you. It's the same thing as, you have someone keep a food journal, right? They don't want to do it. But once you do it, you start realizing what you're
Yeah,
eating, what you're not eating. And same thing as a gratitude journal. You might say, oh, I'm grateful. I'm just like super grateful. I do this all the time. But really putting pen to paper and
correct.
spending that
Yep.
time thinking about what you're grateful for. And really, you said arms, feet, taste, but those are not things to take for granted. I mean, to
No.
be able to see like the things that are in this world, to be able to hear, to not have eh, big issues that you're dealing with. And maybe if you do have big issues, maybe they're not bigger issues. And knowing that you can still put one foot in front of the other, and if you can't, you can put one hand in front of the other. Like there's something to be grateful for. And I think the act of doing that really changes your mindset. It's
Yeah.
not a quick fix. None of the problems that we're in right now are quick problems. So they're not going to be quick fixes, but one day at a time. And,
Absolutely.
I
Amen.
think it goes a long
This
way.
is absolutely, and this makes me think of somebody that I'm going to say and wrap this up with is my oldest patient in the practice, and her birthday is next week, is Pearl, 103. And every time I see Pearl, which I only see her in the office maybe 2, 3 times a year, her daughter, who's about 75, brings her in. And I say, hey, Pearl, come on, give me some wisdom. You got to give me stuff. and she's still mobile. She's got a walker, but she still gets around. 103, she's on, keep her on one med that is, we won't even get into that. But my point is the fact that she has one med at 103 is amazing. And
Amazing.
yeah, exactly. And I say, Pearl, though, come on, you got to tell me the secret sauce. What is it? And I ask her this all the time just to see if it changes. And it's always like in her cute little voice, it is, you got to keep moving and you just can't worry and you got to be grateful for things. And if you're lucky or fortunate enough, you got to keep family and people around you. And I'm like, wow, well said. And it's worked for her. But I mean, if we stick with that, life can be really good.
It's all a matter of perspective, right?
Yeah.
Amen,
Yeah.
Pearl. Happy
Amen. Yeah.
birthday.
Yeah. Happy birthday to Pearl. Well, Dr. Caloia, thank you so much. Tell hello to Brad. And I appreciate you joining me. Your kids are amazing. I didn't bring that up, but you got awesome, beautiful children. You're doing a wonderful job with them as well as the community and taking care of us. So thank you. And again, you guys out there, I appreciate you joining us and sharing this and subscribing to the podcast, where we continue to bring you great guests, great education, insight into health and the journey of life, and just to keep us thriving and not just simply surviving. So be well, be grateful, and we'll see you next time on the Deep Six podcast.